In Chapter 12, we talk about CNS, depressants, and muscle relaxation. So think briefly about what that CNS system does and how when we depress it, what we're going to see with those individuals. So a depression in most of their vital signs is one of the biggest things, and their level of consciousness at the same time. Some of our key terms here, and then some of our drug profiles that we'll go through. I'll pull those out in just a minute. When we're looking at the drugs in this chapter, I want to point out these two terms, sedatives and hypnotics. So a sedative can reduce that nervousness, excitability, irritability without causing sleep, but the sedative can become a hypnotic if we give it a large enough dose. The hypnotics do exactly what the sedatives do, but then they also induce sleep, and they're more potent, which means if you got if this reduced your nervousness, this really reduces your nervousness. So it's more impactful than our sedatives. So think sedatives and reduce all of that, all of our excitability, nervousness, don't make us go to sleep, whereas hypnotics actually can put us into sleep. Then our drugs in this chapter, we're going to look at a few. We call them sedative hypnotics based on what dosage they're given. Can be sedative, but then it can move to hypnotics if we give them in a high enough dosage range. So we're going to look at barbiturates, benzodiazepines, and then some miscellaneous drugs. Your book goes a little bit into the physiology of sleep. You guys know me. I am completely anti-pharm, and I like non-pharmacological things. So think about some of the ways we can support sleep without using these medications, and then there's a nice cultural implication on sleep. So our first drugs that we're going to look at are our benzodiazepines. With our benzodiazepines, they're going to depress that CNS activity and inhibit the brain stimulation. So it's slowing down, it's making that brain calm down. What I want to point out here is if you see a trend, all of these end in AM. So benzodiazepines end in AM in their generic name, so that's going to help us remember them really well. We're going to use the indications for these is that sedation or relief of agitation and anxiety. We can also use them for the treatment of anxiety and depression. We can use them to treat sleep disorders, and if we need it for skeletal or muscle relaxation and acute seizures. The contraindications for these are drug allergies, glaucoma, and sometimes pregnancy. Then our adverse effects can be, it does have a black box warning, meaning with sleep we can have some sleepwalking, we can have sleep driving, so they need to be monitored when they're on these medications because we don't want them to do those and harm themselves. They also have a high risk of abuse and dependence. And then we want to make sure that if they have excessive doses of these medications, they want to avoid mixing them with alcohol. We can also see some headache, some drowsiness, some paradoxical excitement. We see this a lot of times with our very old and our very young. So kids and our geriatric population can have that paradoxical excitement where you think it's going to calm them down and make them less nervous or less anxious, and it does just the opposite of that. We can also see vertigo or cognitive impairment or even lethargy. So we usually tell individuals when they're taking any of our benzodiazepines not to make any important decisions, like don't change your will when you're on these medications. They're also noted to have that hangover effect, and then they can you can see some rebound insomnia with these medications. Because of the changes in their mentality, it can increase the fall risk in our elderly population. So we want to use the smallest dose possible with those individuals. And then do be aware of the toxic management for these. If they have overdosed on these medications, we really can't give anything to reverse it. So we're going to support the vital signs that it's saying. So if I have a CNS depressant and they took too much of it, we're going to have to watch their respiratory depression. So support that respiratory status. If they took too much and it causes them to have hypotension, then we're going to support that vascular system. We might have to give fluids to increase their blood pressure. And then we always want to make sure that we're doing good teaching not to take these medications with other CNS depressants, and alcohol is one that people don't typically think of. So we want them to avoid taking alcohol at the same time with these medications. When they take them with other CNS depressants, not only will we see that sedation and that confusion, but we can also see a further reduction in that blood pressure and a further reduction in their respiratory rate. So make sure you're checking those two things. Also, over-the-counter wise, we want to make sure we're noting if our patient takes any other herbal supplements such as kava or valerian root, which you can buy it on Amazon. So that's going to further potentiate that sedation and that respiratory rate decrease. We can also see some food-drug interactions. I think I mentioned grapefruit juice the other day. If we have if we take grapefruit juice at the same time, it can increase the infect and it can potentially increase the toxicity. So we want to make sure we're avoiding that with those. Remember that most of our benzodiazepines end in that AM or that PAM. And I'm going to point out 3 specific ones here. This first one that we see here is diazepam. And on this one, we use it to treat anxiety. We see this a lot prior to procedures. So if an individual has to go in for some type of procedure and they get really nervous about it, we can use diazepam to help them calm down from that. Anticonvulsants. The good thing about diazepam is it can be given orally, so PO. It can be given rectally. It can also be given parenterally, which is a good thing. Another one I want to point out is midazolam, which is Versed, or that midazolam can cause some moderate sedation. It also has that amnesic effect that I mentioned earlier, especially when my patients are taking, I think I mentioned it in chapter 11, when patients have that conscious sedation that helps them not remember that they were having a colonoscopy. This is our drug of choice for that one. Temazepam, which induces sleep. So we want to make sure, let me roll down to that one. When we take temazepam, since it induces sleep so quickly, we want to make sure that they are somewhere where they can get to bed. So they don't want to take it and then have to drive home. We want to make sure they're at home where they can get to bed as soon as they need to take that one. And then I have 3 that are non-benzo medications. So they're non-benzodiazepines. Sorry, I'm not supposed to use that word. Encephaloclone, Romaliton, and then sulpetamine. On these 3, they are non-benzodiazepines, but they work similarly in that they induce sleep. Some of the specifics for these medications, this first one, we should be able to allot 8 hours of sleep. So we want them to be able to take it and have 8 hours of uninterrupted sleep. On Ramulton, it's very similar to melatonin in that it mimics your circadian rhythm, and it's very useful when you're having difficulty getting to sleep, but not when you don't have trouble getting asleep, but you have trouble staying asleep. And then zolpidem, which is the last one, right here. Our zolpidem has a lower incidence of daytime sleepiness, and it also allows for a quicker onset of sleep and a sustained release to help you sleep longer. A negative aspect about that zolpidem is that we might see somnambulation, which is sleepwalking, so be aware of that one. Our next group of CNS depressants are the barbiturates. So over here, we can see our barbiturates. We have 2 of these. So on our barbiturates, they cause CNS depressant and they impact the brainstem to tell that CNS to slow down, calm down. It does do a good thing of raising the seizure threshold. So if I have someone prone to seizures, it makes their brain less excitable. So it raises that threshold. It makes it harder for them to have a seizure, basically. Some of my indication for my barbiturates is if I need that sedative hypnotic effect based on what we need it for. So it can be used for ultra short anesthesia. We can use it for short-term, short-acting control of seizures. And then if I use it for a longer term, we can, for a longer control of seizures, or then for epileptic seizure prophylaxis. Remember that prophylaxis is to prevent it. So that would be to control seizures. The contraindications for our barbiturates is drug allergies. I'm going to say that every time. Sometimes pregnancy, respiratory difficulties, and then kidney and liver disease. Think about respiratory difficulties. If they have a low respiratory rate to begin with, we would use this very cautiously and then monitor their respiratory status. Also on our barbiturates, we're going to use that very cautiously with our elderly. It really puts them at a risk for falls. Some of our adverse effects that are associated with our barbiturates are drowsiness, lethargy. We can have some dizziness, some of that hangover feeling, and then that paradoxical either restlessness or excitement. It can impact long-term sleep cycles, so we want to make sure we're not using this long-term, but just for the short-term use. And then I did want to point out on our adverse effects on the table that it can cause some respiratory depression. So we're seeing respiratory depression come up frequently in this chapter. A few things to note on the interaction. It does have an enzyme induction, meaning it acts to metabolize many of our drugs, which shortens the effectiveness of the other medications. So we'll mention that as we're going through our textbook. If there's other drugs that have this enzyme induction with barbiturates, we'll mention that, which means they shouldn't be given at the same time because the barbiturate will make the other medication not work as effectively. If we do give it with other CNS depressants, it does cause that respiratory depression. And then we want to make sure we're watching these individuals with MAOI. If they take MAOIs at the same time, which are our monoamine oxidase inhibitors, it can really cause some issue with our MAOIs or our anticoagulants. It can decrease their effectiveness, and it can decrease the effectiveness of oral birth control. So we want to make sure they're using a backup form of birth control for those individuals. Overall, with our barbiturates, we want to note they're not as popular as our benzodiazepines because of their adverse effects and because they can be habit forming and they have a very low therapeutic index. So it's very, very difficult to give them enough to work, but not too much to be toxic. We do treat overdoses symptomatically, meaning I don't have anything that will block it, but we'll treat them to support the airway and ventilation, and we'll probably give them some oxygen as well. And the last group of drugs under our CNS depressants are our muscle relaxants, and they do exactly that. They can have sedative effects other than just relaxing the muscles. Let me go over here. They can work on those muscles to relax them, but it can also have some sedative effects. We use it usually for the relief of muscle spasms. It's best if we use them in conjunction with physical therapy, or if an individual has muscular sclerosis. This is a good medication for that. The contraindications for these drugs are drug allergies or renal impairment. So again, check that renal function by monitoring their urinary output. They can have adverse effects of euphoria, lightheadedness, dizziness, and drowsiness. So automatically that makes me think fall risk for everyone, but especially my elderly. With my GI, I can have issues with constipation and weight gain and sexual dysfunction. If they overdose, we're going to treat that symptomatically. There's nothing to bind with it, so we treat it symptomatically. And then these drugs can have some interaction with other CNS depressants and alcohol. So again, monitoring when they're taking it, making sure they're not taking it with other CNS depressants, and teach them not to drink while they're taking it. The drug of choice on this one is my baclofen. So my baclofen, the benefit is it can be given orally, PO, or parenterally titrated to get the best result on that individual. And I have one more flexible. Cyclobenzaprine. We use this one usually for musculoskeletal injuries. The negative aspect is it does cause that marked sedation, so it makes them to be very sleepy. Check out your nursing assessment at the very end. So what do I need to know prior to giving these medications? What do I need to know while I'm giving the medications, the implementation? What am I watching for? And then that evaluation post, once they've taken the medication, what do I need to be aware of? And since we're still in that CNS depressant, I think I went too far. Since we're still in that CNS depressant, always think respiratory status with these individuals.